right, well, welcome to Journal Club. Today is December 20th, and I just got my Facebook notification that we're live, so sign up on Facebook and you'll get that notification as well. Anyone have any interesting cases?
Yeah. I had a decent case and wasn't too medically complicated, but it was cool. Got a call for a cardiac arrhythmia in high school, so went and I figured it would be a teacher or something going on. Turns out it was a 17-year-old girl who had a history of SVT, whose heart rate was going at around 190 or 200. Looked well, vitals were good. It was just interesting to see. I feel like I don't see too many kids with SVT. But we tried a whole bunch of different maneuvers. Did the EK first a rhythm strip and then a 12 lead on her. It was narrow complex, and tried a bunch of the vagal maneuvers, carotid massages, and then we tried that new one in the recent studies that came out with that like inversion type of thing when they do the Valsalva and then blow and then lay down flat and raise a passive leg raise up. That didn't work either. We ended up giving her 0.6 of adenosine, 6 milligrams of adenosine, which broke it right away. But it was just a good case. I like doing stuff that when we intervene, it actually makes a difference right then and there. She was feeling a lot better. And I think it was just nice because afterwards we had the opportunity to have a discussion with the paramedics about SVT and wide complex tachycardia versus narrow complex tachycardia, and what to kind of think about if you see something that may be an SVT and then the potential cause of it. And then we talked a little bit about WPW and then what happens with if you have WPW and you have a new wide complex atrial fibrillation, how the treatment of that, you need to kind of think about what you're doing before we just give beta blockers or calcium channel blockers, because if people are in WPW in that case, and you give them and you block their AV node, you're basically just going to have only an accessory pathway working, and people will go into cardiac arrest, and a lot of which is refractory to medications and shocks. So it was kind of just a nice little review to talk about with there, and nice to see interventions that were done, but medically, I mean, not too crazy or anything like that. It was just a good case.
So do you guys actually try the leg raising for SVT? I've tried it a few times.
I've tried a few times. I figured, I got a 17-year-old girl who said that she's always had it converted before on its own. So I figured I might as well give it a try. Everyone looked at me like I was a little crazy. I was it was in the nurse's office in school, and then the EMTs and paramedics were there, and I don't know how many people know about this yet. So she was sitting up in a chair. I'm like, let's bring her over to bed and lay her down and doing this whole thing. It looks kind of like a joke or whatever, but whatever. We tried it. People got to learn something new. The nurse was cool. She was like, "Oh, I used to work in the ICU. I'm just waiting for that flat line on the monitor." I'm like, "Yeah." So, but it didn't end up working out. But I think it's worth a try. Why not?
Yeah, it's a non-invasive thing that we can do. We reviewed that paper last year.
The REVERT trial.
Yeah. And it had good data. I mean, while you're getting ready to do all this other stuff, it's something that your partner can try while you're drawing up the meds.
I've done it several times in the year with good success. It's all about, they've got to do a real Valsalva. That's why I like the little syringe and try to have them blow it out, because it's literally impossible, but it makes them do a really good Valsalva and then immediate, head down leg raise kind of in quick succession.
I tell people to bear down and, as if they're trying to go to the bathroom, but please do not go to the bathroom, because people do. And the thing with the syringe is one that works. Some people will use straw. Some people will use an ice bath and kind of dunk the head into the ice bath. Is there anything else? Anyone else have any experiences? Or?
So just to recap the REVERT trial, I mean, that was 2015. I just Googled it really quick, but 428 patients, so great. And their number needed to treat for their primary outcome, which was conversion of the SVT back to sinus, was 3, the number needed to treat. So 17% in the standard Valsalva arm, and then 43% in the monoside Valsalva where you raise the light. So it was a great study, and it makes a profound difference. I mean, number needed to treat of 3, that's better than aspirin, that's better than TXA, that's better.
So the one question for you is, So the 6 milligrams work. What's your next step? So I always try to teach residents and other people that I work with that, you know, it's not like what's the first therapy, is what happens when your first therapy doesn't work. What do you do next? What do you do next? Because the last thing you want to do is when someone, you know, someone's heart stops or someone's in acute distress, to be like, well, let me look that up. There's no time for that.
Yeah, I mean, again, I think when we're looking at these people, anyone who's unstable in some sort of tachyarrhythmia, electricity is going to be the treatment of choice. This girl was stable. If the 6 milligrams of adenosine didn't work, I would have tried 12. I would have tried another 12. If that still didn't work, you know, as I'm doing this, I would probably be giving her fluids, just trying to think about any potential cause of what's going on. I probably would not shock someone who's stable, so especially someone in this like kind of age category. I think it could potentially be traumatic. I don't see really for someone who's stable who I can get to the hospital safely. I would rather let everything kind of happen there. I also think sometimes less is more that we do in the field, and you know, doing some you know, it is important to intervene in certain cases. In other cases, I think it's also important to step back and say, you know what, this isn't the optimal place to do this. The person, we can get them safely to the hospital where they have a lot more resources, a lot more time, more backup there, and let that kind of happen there. So that's what I would have, that's what I would have done in this case.
And then thinking about the wide complex or the possible WPW patients, I mean, you have to think about the safest pharmacologic treatment. Absolutely. Is procainamide, right? Yeah. Very well tolerated. Yet you do have to. The dosing's a little complicated. The endpoint's a little complicated, but it's still pharmacologically the safest medication that we can give for the WPW patients. Yeah. So procainamide, we don't have that pre-hospitally on the trucks. The paramedics used to have it. They don't have it anymore. But we do have electricity. So if someone is unstable, yes. So and I think it's important to know, and I try to tell as many people as possible, because this is a preventable death, basically. If you give someone a calcium channel blocker or a beta blocker and they're in this wide complex AFib, you could kill someone like that. And it's important to know and recognize that on an EKG and not to do that intervention. And you know, like you said, electricity or procainamide would be the treatment of choice in that case.
Any other interesting cases?
Interesting case I had the other day. Was out on a call. It was a call for unresponsive. BLS got there really quickly, I think like a minute or two, because they just happened to be right in the area. This gentleman had collapsed in front of his friends. Friends really didn't know much of his medical history or anything else about him. They denied any drug or alcohol. And basically when BLS assessed him, he was kind of altered and then really lost pulses kind of in front of them. They started CPR. We got there maybe 3 to 4 minutes after they were doing CPR. And while they were doing CPR, they said he was actually it was moving. He was trying to speak. He was trying to grab at the oxygen mask. Then they were worried maybe he has pulses. They stopped CPR. They checked pulses. As they stopped the CPR, he stopped his moving. And then basically that's when we got there. So it seemed like they were just doing really good CPR that was perfusing the brain. I think they were there that quick. I got a couple of shocks by them. And then we were able to shock one, gave one round of epi, and by that time he actually had a pulse back. Look, when he had the pulse back, it was an AFib, so it was kind of unclear exactly what happened. Was this just like a nuance at rapid AFib, and maybe it was super hypotensive? Was it a true cardiac arrest? It was just kind of unclear, but BLS was very taken back by the fact that he was moving during the compressions, but when we had him on the monitor, he was in a very, very fine VFib. So it looked, it wasn't a true arrest, but it was just really good CPR.
Did you get a chance to look at the heart?
We didn't have a chance to look at the heart just because we were so close to transporting, and the ultrasound was still in the physician truck, and I just really wanted to get him transported because we were still trying to put all the pieces together, and it was in a very small vehicle. But he ended up having a good outcome, and I think it was all because BLS did really good CPR really quickly, shocked really quickly. It was, a young guy that presumably will walk out of the hospital totally normal.
It was all manual CPR?
It was all manual CPR, yep.
I've seen this a handful of times now. I mean, it's probably at least 3 or 4 times I've seen where CPR has been done to a point where you're actually perfusing the brain well enough to where the patient becomes alert. and sometimes they're a little combative, but they're actually alert. And then as soon as you stop CPR, it's literally like you're turning off a machine, and they pretty much become unresponsive. So
like that one case you had, your patient, you were making jokes with her while you were pressing on her chest.
Right. So
like, how are you doing, ma'am?
How are you doing, ma'am? And she's like, I'm doing okay. We're doing compressions on her. I mean, it's crazy, but like it happens. I mean, even one time, I remember like 2 years ago, we ended up RSIing someone in cardiac arrest because they were being perfused so well to tube them. I mean, so it happens every once in a while. You'll get it to where, you get the ideal compression, you get the ideal rate, and you get, the ideal oxygenation with perfusion, and your CCP is perfect, and then you've got perfusion, and but it's amazing to really see when they stop what happens.
Yeah. So what do you do with patients if they're in cardiac arrest and then you start doing CPR, and then every time you're doing the compressions, they start waking up and fighting you off or whatever, and then you stop, and then they go back into cardiac arrest, and it's just a constant cycle.
So what they've done is they've RSI'd them or ketamine them, and this actually came up a lot with the mechanical CPR devices. And once you turn it off or once you start CPR, they go out again. And I think we reviewed it last year, but the evidence right now shows no benefit with the mechanical devices. But personally, I feel like it's doing something right. I like them, but can I have like a organization spend thousands of dollars on it with no good outcome data right now? Not really. I'd rather have a defibrillator. I'd rather have therapies that I know will make a difference, will make people walk out of the hospital alive.
I think ultimately, like to me, it's a good sign. I mean, you got somebody who's perfusing their brain. At least we know that, there is a high potential for a good outcome in this patient versus someone having an anoxic brain injury because they've had a persistent long, downtime. So for me, this is the person you want to work on and try to actually, revert their underlying cardiac pathology that's causing them to arrest. So I mean, I think, it's a good outcome. I mean, you just RSI them where you can sedate them, and I think that's just totally reasonable to do.
Yeah, I mean, I think I agree with that, and I think it's also difficult in certain systems if you don't have RSI, let's say, and and how you're transporting now this person. I mean, if you have the mechanical CPR, it's easy to do CPR, but also if you're in the back of the ambulance, I mean, it makes management difficult. The person who's in cardiac arrest who's an anoxic brain injury, okay, if we're not doing compressions or we're missing some here or there, it's not ideal, but at the end their outcome is not very good regardless. Whereas here we have this person who has potential to have a great outcome, and now it just and it's difficult to.
Right. I mean, this is why we stay in play by and large.
I think we have one more comment on this from the other side of the room. Do you want to just?
How about dropping a king tube? So you don't have to RSI. It should be a lot easier to do that. I mean, I've RSI'd also in a cardiac arrest on a patient that we actually used a Lucas Thumper for an hour and 15 minutes. Shocked 18 times before we had double sequential. He was 37 years old, and I speak to him probably once a week.
Yeah,
so
I know
he was actually a paramedic, and he went down on Super Bowl Sunday. But we RSI'd him, and the phone call that I had with the doc was pretty interesting. I said, "This is going to sound crazy, but he's clenched." So we RSI'd him and dropped the tube, worked for an hour and 15 minutes, and he didn't lose anything. But that being said, we're big fans of the Lucas Thumpers.
Yeah, I think you guys had a lot of good outcomes.
Perhaps because we get there quick, and we do a lot of training to eliminate the hands-off time. So even while we're doing it, the compressions are going on until it's set up and it's there perfectly. So I know other organizations as well who have used them and benefited by having a really short hands-off time.
Yeah, I mean the studies that we see that show what's the time that it takes to deploy the Lucas. I mean, it's like 34 seconds or so. I mean, that's entirely too long.
Right. So
you're perfectly right.
We don't do it right away. I mean, we start with compressions, and then as we start to progress through the code and perhaps making a decision to transport at that point, but we don't delay it at any point.
Yeah.
So what he's saying is that the average time is about 36 seconds to put on a mechanical device. With training, you can cut that down to 6 seconds, but more importantly, you have natural pauses while you're doing a code. You stop for a pulse check. You stop to put something on, and you can utilize that time to put the backboard for your device, on while you're doing something else, or you're stopping anyway. Then continue compressions, and then at your next pause, put on the attachment piece, and then switch over. Is there anything else?
Does anybody remember with the study that we reviewed on the mechanical devices? I know they said there was no benefit to them in the study, but did that take into account transport and the difficulty doing adequate CPR and transport in the vehicle?
So that's the thing, it didn't really take that into account. So the biggest thing is that we don't know when these people go down. The best thing that we can have is witness cardiac arrest, and then someone on the chest as soon as possible. And I think why our colleagues have good outcomes is because they get people on the patient within minutes of a call. Like, it's amazing. I've been on some of them, and it's just like, I was across the street and you already have someone there.
There's a psychological side to it also. When you're a paramedic on the scene and someone's doing CPR, and they need to switch every 2 minutes so that they don't pass out, it makes you need to get your tube in, need to get your peripheral devices in a real big hurry. And when you do things in a hurry, as we all know, they don't work.
Yeah.
If you have that Lucas device pumping, there's a relaxation that the paramedic has, that he's able to go in and do what he needs to do, and the CPR part's being covered, and it's being covered well, and he's watching it on the monitor, and he sees the ETCO2 coming out well, and he's watching the patient respond properly, and the patient's color's good. He's not overtaxing himself to try to get this done in a super hurry to keep his BLS guys from falling apart.
I mean, that's a huge point. I mean, I think even for me, from the perspective, you know, when you have someone who's on a Lucas device and getting adequate compressions, consistent compressions, that's huge. It offloads you even to like having that mindset of, you know, is CPR being done properly, and having to look at the person doing CPR and taking them off. Now you can take a step back and run the resuscitation, and you're actually now, your mind is a little bit worry free. So I mean, you know, when we get, you know, patients coming into our ED and where I find pre-hospitally where we have the Lucas device, you can actually now take time to think, take time to figure out what could have caused this and what reversible causes that we have to treat this. And that's a huge, I think, component that we don't even talk about in regards to kind of resuscitations. But, you know, certainly not only that, but like, let's say you make the decision to transport, the safety aspects are paramount. I mean, you know, from a perspective of transportation in an ambulance to the facility, you know, you're really preventing, you know, significant injury in the back of that rig by putting them on the Lucas. And then, you know, even transport to the actual ambulance from, you know, the patient's home or wherever they're in arrest. I mean, you're getting adequate compressions throughout the entire time, which is huge. Because the last thing we want to do is go through all this work and effort, and then the moment you start transporting someone, you know, you lose everything that you've done because the CPR completely just diminishes when you do manual.
And we just have to say we have no financial conflict of interest, so we do not endorse any specific product.
Right.
There are many mechanical compression devices. There are many laryngeal tube airways out there. We don't endorse any single one. There are a few comments from the crowd who's watching. Everybody's very actively participating today. But just in regards to cardiac arrest, Tim Sullivan's just saying another available utility or a tool would be the ultrasound, which we're doing with the physician vehicles now. But in PEA, look at the heart, see what's going on. If the patient's profoundly hypotensive, for example, the heart will be squeezing well, but there's just no volume there. So that really changes and affects your management. And he said, what about ALS having them? I think, you know, there are some systems that are using or going to start maybe including that in their ALS training. It's just such a huge training endeavor. It's probably expensive, and you have to commit to buying ultrasounds that are going to be reliably used. So maybe in the future. But
well, as of right now, I think ultrasounds are close to $10,000 each.
Yeah.
That's
a couple years, maybe it'll be a couple
What-
hundred.
Even more.
What's the new device that hooks up to your iPhone?
There are multiple. But yeah,
there's multiple devices that are out there now. The recent one that we're kind of really interested in is called the Butterfly.
That's it.
And
but we don't endorse anything in particular.
Right.
We've already been flagged by Facebook for including names, so we just have to say that.
So, and that's basically like $2,000. I mean, worth. But I mean, there's a lot of training that goes involved with it, obviously. But there's been multiple studies done in ultrasound training with paramedics, and all the trainings that have been done pre-training and post-training. there's a huge learning curve, and I mean, you get to the 90 percentile in really kind of differentiating between a hemothorax or cardiac standstill versus an effusion, and versus cardiac motion. So I mean, it doesn't take much. The learning curve is huge. All you need is really just a couple training sessions, and you can actually ultrasound pretty well. As soon as we start driving costs down and we're able to get these portable ultrasounds in the field, I mean, this will augment our care extensively. For me, in the cardiac arrest, that's huge, and especially with PEA. Tim's right. Like, I mean, you have these patients who are profoundly hypotensive. You see an actual bradycardic rhythm, but you do the ultrasound and you actually see there is some type of EF, correlating with your heart rate on the monitor. This is the patient that you start an epi-drip on during cardiac arrest, because this is why you want to bring them up a little bit. Or if you have levofed, put them on a levofed drip. But this is kind of how it augments your ALS care during that cardiac arrest.
Yeah, I think there was a time where I went to a call and medics were on the scene. They already started everything. They were at the point where they were just like, they were considering calling it. And I put the ultrasound on the patient and I saw that the patient had squeeze. And I started an epi drip at that time, and the squeeze got harder, and there was no palpable pulse, but I could see that the heart was squeezing. And then by the time we packaged the patient and got into the ambulance, it was a good blood pressure.
So you stopped CPR at that point?
We continued CPR until we got a better blood pressure. So,
but by the fact that it's squeezing is, by definition, patient's not in arrest. We simply need to supplement it, similar to what you would do with a child.
Until we have like an A line or something that we can actually measure that blood pressure.
There's a lot of data coming out now. There's just a huge meta-analysis looking at if you see a contractile motion on a heart, it may actually be detrimental to the patient in terms of their outcomes to push on the heart and do CPR, because you're going to be basically going opposite or undoing whatever their heart's trying to do on itself. That's why ultrasound is so important to
And the debate now is, even if the heart is squeezing, is it enough to perfuse the brain? Because everything else can kind of, wait for a little while, but the brain doesn't like being starved.
But these are where, like, in the emergency department, I'll start with multiple pressors when I see that kind of, ultrasound finding, versus just putting on an epi drip. I'll throw them on an epi and levo at the same time, and to augment and try to bring that heart rate back up, because I know that the heart's squeezing. Now I just got to get the inotropic effect to where I can get actually a map that's sustainable.
We had another interesting case.
Yeah. So, despite my generalized objection to an automated CPR device that has no particular name or brand, I actually had a patient the other night who I probably would have benefited from some type of automated device. A 40-year-old male came across his chest pain. He actually went, and not to take it personally, but as I said, "Sir, how are you doing?" He actually went into cardiac arrest. So I don't know if it was my touch.
How does that affect on people?
It's the wrong kind of touch.
No. So we actually arrested in front of us. The arrest ended up being 80 minutes, 75, 80 minutes, 9 epinephrine, 3 single defibrillations, and then 5 dual sequential defibrillations, 2 amps of sodium bicarbonate, 2 milligrams of Narcan. We didn't have any calcium on the truck. And after a while, we ended up terminating. Essentially, it may have been a fine V-fib, but it looked pretty asystolic to us. Multiple call-ins to command, so if anyone received a call from my partner, that was from us. But it was one of those arrests where, given his age, we found out later the family wasn't terribly forthcoming with his history, that he had an MI at the age of 16. So his history was significant at that time. And then as time went on, he was complaining of indigestion from the night before. So he was probably infarcting the entire night. And then at whatever time we got there, which was around like 5 o'clock in the morning, that's when he actually arrested. So the working of the code, we had enough resources available to us. The fire department came out, so it was a really good pit crew approach to the arrest. The intubation went well. His end tidal dropped down to around 12 when we had a fatigue compressor, but generally his end tidal stayed between 20 and 56. So it was one of those arrests where we simply just ran out of medications and resources to keep working them. Again, I'm not a huge fan of the automated devices, but that would be one context when that probably would have been beneficial.
Would you have transported if you had an automated device? Or was that a reason not to transport?
No, I mean, against my better instincts to transport him, yeah, probably. If we had one available to us, it probably would have made sense to take him. Where we weren't. We also weren't in an ideal location, so we weren't really anywhere that was within 10 or 15 minutes of the cath lab. It would have been a 25-minute transport. So that would be another consideration to take in as well. So, not an ideal outcome, but everything went well except for the end result. So the end.
Yeah. So yeah, sometimes it's just, I mean, if that's why ultrasound plays such a large role. You can see if it's just a huge infarct and the whole left ventricle's not moving, sometimes you can only do so much. The infarction process is a dynamic process, but oftentimes we get to it too late. It's stuck in a very large vessel, and you can't do anything. Plenty of paramedics are chiming in, including Jose, who says, "I would love to learn ultrasound." So maybe we can talk to Vince about that. Just kidding.
I think knowing your equipment and knowing how to set this up is, the average, if people do have any sort of mechanical compression device, the average EMS unit is not doing a cardiac arrest a day. So if you're only dusting it off, once a week, once a month, whatever it is, if it takes you that extra time to set it up and you don't know what you're doing, you put it on backwards or whatever. So if you're going to use this thing to save someone's life, then take it out, practice with it, use it a bunch of times when you don't need to, because we're only as good as our equipment basically, and we need to be able to use it proficiently and quickly in a timely manner.
Any other interesting cases? Or should we move on to the article?
Josh,
I have one if I
did
could.
you want to talk about that 252 case? I just thought I thought that was really interesting. That's all.
Yeah, I mean, I wasn't there. I know just a little bit about it. I mean, I saw a video and I talked to one of the paramedics who was on the scene. It was 252 up in I think it was in Elizabeth. It was Jose and AJ. I mean, I think that these guys really saved two people's lives. They were transporting a patient who had a stroke to the hospital. And while they were transporting, they noticed that there was a car that was smoking. And after being involved in a car accident on a street, they had immediately pulled over their ambulance, and one of them stayed in the back with the patient, while the other one went out and actually got some bystanders to drag these two guys out of a smoking car. And from what I heard, these guys were really big, and both of them, I think, had broken legs, so it was not easy to get them out of the car. But with their quick actions, they were able to get them both out quickly by utilizing bystanders that were there. They dragged them far enough away. Actually, from what one of the paramedics was telling me, that he was worried that they weren't far enough away at first, so he dragged them even further away. Shortly afterwards, apparently the whole car just exploded, and these guys would have for sure died. So it was really amazing to hear, and I think there are amazing stories out there. This is something particularly happened to be in the right place at the right time and really took the appropriate actions, and utilizing the people that are around, because nowadays when everyone has their cameras and their cell phones, they're all just sitting there videotaping it, and we forget that we can use other people that are there. And I think it's definitely important to be able to recognize the resources we have or don't have, and then utilize the people that are around there and give people a responsibility and put them into action. So great job, I think, to those guys, to Jose and AJ, and then to anyone else who came and assisted as well. But I mean, they really saved these two guys' lives, and and their families, and who knows what else these people are going to do with the rest of their lives. So yeah, it's a great job.
Yeah.
Hope you guys at home have tissues. That's all.
There's a couple questions from the Facebook crowd. So Tim Sullivan asked, why not run an epi drip basically during a systole or PEA? I mean, we're giving epinephrine 1 milligram, every 3 to 5 minutes. So I mean, they're getting these boluses of epinephrine. I'm not sure the utility of giving in a systole if there's no cardiac motion at all, or if you don't really see any evidence of cardiac motion. The utility of an epi drip may not be there. The utility of epidrip, when you see some contractility, is really because you're actually seeing physical motion, and you want to give a consistent kind of titration of epinephrine in that can actually augment it consistently, versus getting these high peaks of boluses of epinephrine. But what we're trying to achieve with epinephrine obviously is ROSC and then sustained ROSC. And that's kind of what epinephrine does at the end of the day, but it doesn't really change mortality, unfortunately, that we know. Another question was about calcium chloride being on back order. I guess for our system, I mean, why not carry calcium gluconate? I think it's not unreasonable if you can do it in your system to carry calcium gluconate, but just know that obviously if with calcium chloride, it's a lot more potent. So you would have to give 3 grams of calcium gluconate to equate to 1 gram of the calcium chloride that you would normally give.
Gluconate's on back order also.
It is.
A lot of it is the packaging, unfortunately. It happens in Puerto Rico.
Right.
And so it was already on back order. It was already limited supply, and now the packaging is not happening in Puerto Rico at their factories.
Right.
Like that, so.
Right.
Yeah, there's one hospital program at a meeting last week said the only thing that they're getting are liter bags of saline.
Yeah, that's where they're manufacturing those there as well.
That's
Yeah.
the only thing that they're able to get a hold of right now.
All right. Shall we move on to the articles,
Sure.
or any more discussion or questions to address before we move on?
I have a quick case if I can bring up.
Yes, please.
So we were dispatched, I guess about a week and a half ago, to a assisted living facility for a patient who fell unresponsive. Those generally, as you all know, get canceled relatively quickly. BLS got there. We probably had about a 10-minute ETA. BLS got there and said, patient is still unresponsive. As we got close, they were wheeling this patient out of a stairwell, and we met them in the back of the ambulance. And patient's alert. He knows where he is. He says they were having a fire drill, and he was going. He remembered being at the steps, and then they said he fell, and they found him on the landing. So concrete steps going down into a stairwell, and he said he doesn't recall the incident or anything else like that. So he has a big lac in the back of his head that was already bandaged up. We put a C-collar on him, and we start to evaluate him. We find him to be in a sinus Brady, somewhere like in the mid to upper 40s, and he's hypotensive at, I don't know, like in the 70s somewhere. So my partner starts an IV, we start giving him some fluid. We do a quick 12 lead on him, and he has elevations 1 millimeter in 2-3 in AVF. So now we're thinking, okay, what came first? Did he trip? Or did he have an MI and he went down a flight of steps? We were already on our way to Jersey Shore. Am I allowed to say Jersey Shore? We're on the way to a trauma center. We're on the way to a trauma center, so we called the doc and we said, I guess we're going to bring a STEMI into the trauma room.
I think I had that call.
It could be, but they disagreed with us, by the way. So we transmitted the EKG, and he was complaining of shoulder pain. But it hurt when he moved his arm, so we figured it was just associated with the trauma. As we come up to we called the trauma room ahead just in case, not that anyone ever forgets, and we didn't, but they didn't have the phone call because somebody had called into the ED with that. And when we came in there, they said, no, you guys are going straight to the ED because your STEMI was transmitted. We said, what about the trauma component? We don't know if he has a bleed or anything else going. He went down a full flight of steps. So I forgot to mention that we had asked him to check the video cameras that they had in the stairwell to see if he tripped, if he went down one step, and they checked the cameras and they saw that he actually went from the top step all the way down about 10 or 12 steps. So we took him into the ED and they sent trauma over for a consult, and then they were waiting for enzymes, so they ended up sending him back for a CAT scan. So we were just unsure. I called Dr. M. I called Dr. Merlin, and he was of the opinion that patient should have gone to trauma first, have him assessed and cleared, and then I guess they can, whatever, they'll do the troponins there and figure out if they're going to take him to the cath lab. So just an interesting case. I'm not sure what anybody else would do. If they should go to trauma.
He never went to the cath lab.
Correct.
Wow. And so, because I asked both sides, ED and the trauma, you have that situation, what takes precedence, the STEMI or the trauma?
Right.
And I haven't got a clear-cut answer back yet.
I know he had a fractured. I believe he had a fractured clavicle, humerus, and a couple of ribs, and some other things as well.
Speaks about in the setting of trauma or potential trauma and hypotension we see all the time. We don't always see bradycardia with it. Right. But what definitely should be in your mind in those situations is intraperitoneal blood. Lumps of abdominal trauma will often present as bradycardia with their hypotension. So I think the trauma would be the trauma evaluation should be first before the cardiac evaluation. And look, they pan scan them, no blood in the belly, you still have elevation, sure, take them to cath lab. You're not losing very much by doing that.
Yeah.
Whereas the other way around, take them to cath lab and put them on heparin.
Yeah.
Blood in the belly.
There you go.
There was definite elevations in the 12
No,
league
I-
because
and I
there's
agree with
no
that.
question at all.
We did 5 of them.
Yeah.
Sure.
Did he have enzymes?
Huh?
What's that?
Did he have cardiac enzyme, elevation cardiac enzymes?
I don't think so.
I think this is where it's important to have, when on the ER side, to have an emergency physician that understands trauma and understands the medical stuff. I think these are the patients, and similar to you, I had a guy who had a seizure on the highway and got into an accident, or maybe he had an accident and then had a seizure. I don't know which way it happened. But these are the cases where it makes a difference to have an emergency doctor who understands both the medical side and both the trauma side. And what we're doing in a lot of hospitals nowadays is exactly what you said. They go to trauma side, they don't get seen by the trauma surgeons. Or they go to the medical side and it's a trauma surgery consult. And there's too much disconnect, I find. And I don't think it's servicing our patients well. And, the trauma surgeon can deal with the regular trauma stuff, the ER can deal with the regular medical stuff, but it's these people that are in the middle. And it's like it in a lot of other aspects of medicine, I find, that it's these people in the middle that really get disserviced by having these super specialized care in one specific area. We need people that understand the global picture and who can kind of integrate the two different things together. And I think it's important in ERs especially.
By and large, we should always think of like the chicken and the egg kind of scenario where there is a medical component that has led to someone sustaining some type of trauma. And it happens in seizure patients a lot, and it happens in, unfortunately, like our alcoholic patients or our intoxicated patients, but certainly in setting of the line as well. And the biggest thing is that, rightfully so, there's no way anyone should take a patient who's a trauma patient with like an open laceration, could be actively bleeding and who could be actually bleeding interpersonally or and take him to the cath lab to put him on thinners. So before you can try to anticoagulate this person, you got to definitely put him through the cath scanner. And especially since you guys did a diligent job, I think I applaud you guys for looking at the video even to see kind of what the mechanism was and how far they fell. That's great. Because that really tells you that there was definite trauma, and that patient needs trauma. That's a clear-cut trauma case, and then deal with that medical aspect on the back end, and that's important. But I think many times we do lose sight of that, especially in specialized trauma care.
Move to the articles.
Move on to the articles. And I'll just say while we're transitioning, so this has been a great viewer base so far. We've had at least 20 to 25 viewers constantly since we started. So thank you for everybody who's tuning in and watching. Be sure to share it on your Facebook pages, professionally and personally, so we can increase our user base. And we want to get the good word out. So who's going to go first with articles?
I can go first. So this week we looked at a pre-hospital management of hypothermia. It's basically a review article by Frederik Haverkamp, based out of the Netherlands, in association with some Canadian authors as well. And those are the perfect people to manage, or basically to tell us how to manage people that get cold, because they get really cold up there. And basically they looked at a lot of the devices and a lot of the interventions, and kind of compared them to see what was better. Like, should we be doing something different now? Technology changes pretty quickly. Like, maybe there's some active rewarmers or other field EMS devices that we should be looking into. So basically they kind of looked at the whole body of evidence. They looked through many databases, including PubMed, EMBase, and Medline. Looked for all the obvious terms that you could think of, from basically the existence of the database all the way up through October 2017. They found 900 different articles, of which basically 51 were kind of what they were narrow enough to kind of be useful in this review. And they basically talked about there's a whole bunch of different ways of treating this. One way is you can have a warm blanket. That's just a simple blanket. You've got the person, you put a blanket on them, bam, you're done. Another way was using a combination blanket. For instance, like a wool blanket with a space blanket, those little thin foil blankets that kind of create a vapor barrier. And that helped reduce heat loss, because not only are you trying to you warm the air there, but also you're reducing the evaporative effect, because that's actually one of the main ways that we lose heat. It's a very efficient way. That's why we sweat. Same thing happens when you're wet. That's why you take wet clothes off of people who are cold. When you're wet, you lose a lot of heat very quickly. And so by adding that vapor layer, you can stop that evaporative process. The other things that they looked at were rewarming devices. So there's little blankets that, the little heat packs that we have. There's blanket-sized devices of chemical heating blankets that you can combine with these wool blankets and space blankets. They have water bottles that you can kind of use. There's a long list in the article that if you look it up, there's charts and charts and charts of all these devices, their costs. They have the chemical ones, the water blanket ones, and also electric blankets that you would actually plug in either to the hospital or to the ambulance rig to try to warm patients. And they talk about basically what is the most effective way of rewarming these patients. And actually, when they're going through all the evidence, one of the best ways to warm patients is to kind of let them warm themselves. If the patient is shivering, they're found in the snow, their temperature is low, around 92 degrees is when we start having cardiac arrests or really low flow states that can cause like ischemic limbs and cause lots of coagulopathy. And if we can warm them up by letting them shiver, covering them with a blanket and using a vapor barrier, that's probably the most cost effective, and it does work well. If you have it available, you could use external warming like these heating blankets or the water baths or the chemical break blankets. The other devices they have is maybe you've seen in the hospitals. They have these forced warm air bear huggers that blow hot air. The problem is they're big and bulky and require lots of equipment. Some of the other devices that I thought were really interesting that I haven't really seen before is they have battery-powered IV line warmers. So you basically take room temperature saline, you put on this battery inline warmer, and it can warm the IV fluid all the way up to 104 degrees as it's being actively given. So that's pretty interesting. The problem with using those devices is like you think of most of our transports, how much fluid do you get in? Like 100, 400 mLs? It's just, it's hard to get enough fluid in to make a big body temperature difference. And so really, I think at the end of the day, using a blanket and a vapor barrier and taking off the wet clothes is what they found to be the most effective. There was no combination that was more effective than the other, with the exception being if the patient is not shivering, you need external warming. I remember, and some of the, I'm from Florida where it gets really cold all the time. And we had no external warming devices at all. So on the like 1 or 2 nights that was actually cold into the 60s, we would put our IV fluids right on the front of the windshield because that's where it would heat over the little defroster vent. And it worked really good. And I think maybe once we've used it, and probably just to use it because we just don't get that many hypothermic patients. But I think that's like a practical and cost-effective way. That's what I do actually now when we're out on these calls and it's a really cold day. I throw an IV bag up there because my truck's always on. It's going to be warm. It's an easy way to do it. These inline warmers are pretty expensive, like $500 to even the thousands of dollars. And the problem is it's hard to get enough warm fluid in them. I think really using the basics, right? Taking off those wet clothes, covering them up, getting a good temperature. That's also usually a hard problem to do in EMS unless you have some like disposable thermometers that you can do a real rectal temperature. But getting that core temperature is sometimes difficult. And it's really about suspicion, right? They're found in the snow. You need to warm them up, right? That's why we have that old adage: they're not dead until they're warm and dead, because that cold can really alter and affect you. So at the end of the day, even these people from the really cold climates and the Netherlands and Canada, they say blankets and vapor barriers probably are the most effective unless you need active rewarming. And then all the devices on the market work pretty well. So it's really about what works for you and what can you reliably get and keep in stock and keep charged. But it was an interesting review.
So as you've been talking about the article, I'm actually putting pictures of each blanket up here so people can see what we're talking about. But the bear hugger one, the active rewarmer, when we don't endorse the bear hugger, whatever. It's actually on a dog, so
Oh, nice.
which is fitting because we actually have a lot of the critical care residents from a nearby critical care veterinary emergency program watching as well. So welcome. Shout out to Dr. Tomilowitz and Dr. Carr, my wife. They've been watching for a while. And this hypothermia stuff applies, I think, to all species as well. Well, maybe not snakes and lizards, but definitely mammals. Hyperthermia, I think, is a little bit different because we're not panting like dogs, but, you know.
Well, the other thing is that also for any federal team, we take care of the dog because they are federal workers as well,
right.
And that's mandated by the government.
Yeah, we do that with tactical medicine. We treat the canine units as well. So whenever we're on scene.
So one of the big things with rewarm is that we always have to think about is that you don't want to scald or burn the skin, which is a good possibility. That's why we use targeted temperatures where we're not exceeding the boiling point, or you don't want to cook them basically. Right. And I know that a lot of people may throw the IV bag in a microwave for a couple, like 10 or 30 seconds, although that is not authorized by the manufacturer because it's not tested for leakage of the plastics into the saline. There's always for the EM residents out there, there's always ECMO, but that's very, very invasive. There's also putting in 2 chest tubes in each side and doing lavage and literally just attaching in a hot water, not hot, you don't want to cook them from the inside either. The things to think about for invasive temperature monitors is esophageal temperature monitoring as well as urethral bladder. But if you're using you can also put in a Foley and irrigate the bladder because you warm them internally as well.
There's NG lavage and peritoneal lavage. If anybody remembers how to do a DPL. Now we have ultrasound.
ECMO and dialysis are extreme measures as well, but ECMO they do for extreme rewarming, and dialysis is quick if you don't have.
And with extreme temperatures, just moving them over to the stretcher, you can induce VFib. So.
Right. I think this was a pretty good article. I think one of the reasons why I like is because I like how it differentiated between like just if you're shivering or if you're not shivering. And I think that's a really easy way to kind of just think about things. It kind of simplifies it pretty nicely, and it kind of allows you to see, okay, how aggressive do I need to be in my management? From a very, subjective point of view, you just kind of walk up on a patient and say, okay, what's their reflex? Are they shivering or not? And are they responding to this cold environment? How hypothermic really are they? So I think that's a nice article. It really kind of gives you a little bit of an endpoint of how you're going to start managing patients. And we kind of go through the bread and butter of taking that exposure environment away if they're wet, damp, drying them up, and then rewarming them. But it kind of gives us an endpoint of where we're going to be going with this patient and how quickly can we think we can kind of turn them around. I think the IV fluid warmers are great. One of the biggest things that we think about, pre-hospitally as physicians is, giving blood products pre-hospitally. One of the biggest problems is that, we had, Naud and I had one where we had a bus accident and the poor woman was entrapped for about an hour and a half and she was hypotensive. We gave her TXA. We actually had blood in the field and we were administering blood, but it was like the winter time. She was exposed in this environment. She was entrapped, and on top of that, we're giving her blood. And my biggest concern was she's going to be extremely hypothermic. So we shielded her a little bit. We tried to stuff blankets as much as we could to try to keep her warm. But these are real effects that we have from medications and products that we're giving to patients. And so we always have to be mindful of that hypothermia kind of that we induce in patients just when we're giving fluids or any type of resuscitation.
Right, and in the article they also mentioned that just giving room temperature fluids can induce a significant hypothermia, which we do that all the time without even thinking about it. And these septic people, you can really, not uncommonly, they'll come in at 90 degrees because they've been getting a good amount of fluid and they're already vasodilated from their disease pathology. Yeah. They're very cold.
Imagine giving 2 units of two PRVC units of blood and the impact that's going to have. And those are freezing cold. Yeah.
Shall we move on to the next article? I can go. I'll go next. Hang on, let me just pull it up here. So I actually have my microphone on the computer. Perfect. I think I can hear myself fairly well. It's a little weird because there's a delay, so whatever. But I'm I'm putting up the picture right now. I'm going to talk about an article looking at the utility of CPAP or BiPAP, otherwise known as non-invasive ventilation in asthmatic patients. So let me just get the picture to come on up here so everybody can see what I'm talking about. There we go. Open. Okay. All right. It's not switching over, so just give me 1 second to re-upload the image. All right. Okay, so this is from Australian Critical Care. Here's a picture of the article so we can see what's going on. And essentially, these Australians, Green, Jane, Burduth, they're all various backgrounds. They decided to do this review, a systematic review, to assess whether or not CPAP or BiPAP actually works in asthma. I know this is something we've talked about before. We use it all the time for various reasons in the ED. Heart failure, any kind of fluid overload. It's very beneficial. But theoretically, as we'll discuss, it seems to make sense for asthma. But nobody really knows if it has any benefit on outcomes. So I think that's important to address. So this article, I mean, they spent a great time in the introduction talking about the profound impact of asthma in the United States and internationally. Large economic and physical and psychological impacts play in, as we said, all over the world. And we know the physiologic process behind asthma, but it's always humbling to realize, I mean, over 334 million people are affected by asthma internationally. Now, from what I could tell from that article, that does not include the induced or secondary obstructive diseases like COPD. This is purely being born or developing in your childhood and having it for life. That's an enormous amount of people. They quote a few studies. 5 to 10% of asthmatics are experiencing severe asthma attacks each year. So do the math with that, and of those who are admitted to the hospital, about 10% of them require ICU admission. Those are huge numbers. So it affects a huge amount of the population. God bless you. Anywhere from 10% to a quarter of all these people who are admitted have hypercapnia. That's always something to consider, especially when mental status comes into play if they're altered. And then, depending on the study you read, anywhere from 3 to 10% of those who receive invasive ventilation, like intubation, that's the mortality rate. So people who are intubating with asthma, anywhere from 3 to 10% are having mortality before they leave the hospital. That's enormous. So what can we do to decrease this number? One of the things might be, okay, maybe non-invasive ventilation. So, the physiology behind it, I guess if you think about when in asthma, expiration is becoming more of an active rather than passive process. So you're trying to overcome that resistance by actively trying to expire and push the air out. And that is exhausting. If anybody has asthma, I don't, so I don't understand it really. But it is exhausting, I'm told, and that's why these people tire out so quickly. So what can we do to help them? So what non-invasive might do, in theory, is stent open these airways so that it's easier to expire this air that's stacking up inside of them physiologically. And if hypercapnia is involved, it's theoretically, as we all learned, one way to ventilate all that carbon dioxide is have a difference between your inspired and expired pressures. So that's why in the BiPAP we're doing big differences like 15/2 or something like that to try to expire all that carbon dioxide. So those are a few physiology points that are playing into why we would even consider it. And one important thing that they mentioned, 38% of all non-invasive BiPAP or CPAP starts in the ICU. And 36 of those start in the ED. So their point is maybe we're not doing it early enough if we're going to consider it. So that's why we're not seeing it affect outcomes, which is kind of what we're going to get into the meat of this review. So if you're following along, just look at figure 1. You can kind of see the flow chart. They looked through 433 articles. They narrowed it down to 13 with a pretty extensive exclusion process. 13 articles. that they were able to look at. In any systematic review, you want to see how they're grading them. So table 1 actually shows the hierarchy of evidence of how they're grading it. So you can glance at that. I won't go over it in detail, but basically level 1 evidence, you're going to have systematic reviews, meta-analysis, looking at randomized controlled trials. Level 2 evidence, that's randomized controlled trials. So meta-analysis and systematic meta-analysis, they're going to be the best. So they kind of, the 13 studies, they put them into a table, which really does a great job showing the differences. As you'll see, looking through the table in table 2, their first meta-analysis at the top is their best study. That's their only level 1 that they were able to find. All of these studies, if you look down the list, the meta-analysis, the next few are randomized controlled trials, they all are looking at different outcomes. And that's a big problem with any systematic review, trying to establish whether or not this is actually working, right? So, for example, the meta-analysis at the top, their only level 1 paper, they were looking at non-invasive on mortality rate, which is a great patient-oriented outcome, and the rate of tracheal intubation. And for them, their meta-analysis, it didn't really show a clear benefit. If you look down the different randomized controlled trials underneath that, they all have different outcomes. Some of them are patient-oriented, some of them are not. I think, personally, I don't know how you guys feel, anytime you're looking at an outcome in a paper, you want it to be patient-oriented, because that's really what's going to affect the whether or not you're going to use it in practice. So some of them are looking at pulmonary function testing. Does it matter to me? Not really. I don't know. What do you guys think? Like, is it going to really change your practice if you're not seeing a patient-oriented outcome?
No, I agree. I think when we're doing stuff in the ER or pre-hospital, we need to do things that are going to, make a difference. Then I think it's also important to kind of keep in mind if we're going to benefit a patient, even if we don't necessarily see the benefit, but they're going to have a big morbidity or mortality benefit down the line, even a week from now or whatever, then I think that is important for us to consider as well. Because if our treatment at time A when they come in really does make a difference for them down the line, even if we're not seeing it, I would do that treatment. If it would better the patient. But if we're dealing with like numbers or stuff that just is making us kind of feel better by seeing a number, but it really doesn't make a difference, and stuff like that, it doesn't change my practice as much.
Yeah. So, you look through the rest of it, they really get down to level 3 and level 4 or no level evidence throughout the rest of the thing. And most of these, if you look down the findings, all of their, whether or not they're significant or not, all of their outcomes are like mean FEV1 and everything like that. So just echoing what you exactly said. And some of them do comment on mortality and really the patient-oriented outcomes that we care about. So long story short, all the studies included found either no difference between the control group and the intervention group, so those that had non-invasive ventilation, those did not. They really found no difference, or there were very few that were significant but not patient-oriented outcomes. So I think that's one of the major limitations of the study. It's heterogeneous nature, and there's only one meta-analysis. The rest of the RCTs mostly were not patient-oriented. So they have a really difficult time, as with most reviews, comparing outcomes and standardizing them, which is why I kept asking myself the whole time, why didn't they do a meta-analysis of all the studies? Well, they can't, because all the outcomes are different in every freaking study they looked at. So they ultimately, as they would conclude, I think that's where everybody stands right now, is to say that non-invasive ventilation during asthma appears to be safe. Maybe it's effective, but there's really no comment or no data to support its effect on mortality, length of stay, dyspnea scores, so patient subjective scores, and that are really conclusive. So we really, we don't know. Do you guys use it for asthma?
Yeah, people do seem to get better, though.
Yeah.
If we think about all the interventions we do, when you put people on the BiPAP, they seem to turn around and get better. And maybe they would get better anyway, even if we don't, But if it's an intervention, again, that's not dangerous, that can potentially help someone, and it will make a difference for them, then I think it's a worthwhile intervention, even if we don't necessarily have enough data at this point. Especially, like you said, it doesn't seem to be harming people, so.
Yeah. And whenever I'm using an asthma, the words of my notorious program director are echoing in unless the treatments are in line and they're ready to go. So I think that's really important. You have to have your treatments in line, already going before you put it on the patient. Especially if they're not used to it. It's kind of like, I always tell the patients, like hanging your head out of a car window while you're going 90 miles an hour down the parkway. So I don't know anybody who drives 90 miles an hour down the parkway. But it's got to be something.
But I've also worn it. I just wanted to see what it felt like. I've worn it at like 20 over 10. And I mean, you could feel it, but it's not terribly uncomfortable. Like, you breathe just fine.
Yeah, I think
what if your bronchioles are constricted though?
Well, then I think that would change a little bit, but still, I think.
Yeah, a lot of people who have used it, you've been in respiratory distress for a while. If they've had it, they'll ask for it, because it changes them around so quickly. The other thing, sometimes you can do a staged kind of application where you're just like, okay, we'll put the mask on first, no straps, and then put the strap on, and then actually hook it up. Then actually, get it going.
Right,
sometimes a little Versed will help. Sometimes a little ketamine will help to help with the anxiety.
And you can also gradually go up on the.
Yeah. Talking through it.
Absolutely.
Too. Like, just like it's tough because it sounds like a platitude sometimes. Where you're just kind of like, give it a second, like, and it'll work fine. And then like you get them through the first 2 minutes.
What we sometimes do is we'll actually have the monitor face them, and we'll let them see as their pulse oxygen is going up. So they might be claustrophobic. We say, hey, watch, your sats are going now from 85. Look, now it's at 86 and 87, and it's hitting 90 now. So you're getting better. You might be a little overwhelmed and claustrophobic, but just give it a couple minutes, and then we watch the sats go up to the mid-90s.
And a trick I learned from Haney Malamet, one thing you can do is, especially to people who are BiPAP naive, is take it and put it on their face at really low pressures, like 2 over 0, 5 over 2, and you slowly work them up so that they start to feel what it's like to have the pressure during inhalation and exhalation. And I've done that a few times bedside to somebody who's freaking out and we're ready to intubate and everything, and it's just training and coaching them through the process. And it takes a few extra minutes. Every time I've done it, it's worked. We didn't have to intubate. Maybe that's anecdotal. We should do a study. But it's, yeah.
I think it's very true. Like you said, I mean, with this, there's other interventions that we do that, make people feel a certain way. And we know that they're going to feel a certain way or it may scare them. And I think that taking the extra time, that extra minute or 2 minutes to explain to them what's going to happen, explain to them how they're going to feel, really makes a difference, because it is scary to feel like you have air getting thrown down your throat when you're trying to breathe out, and all of a sudden you have air getting pushed in. That doesn't make sense. And if we take the extra time to kind of explain to the patients that this is what's going to happen, this is what you may feel, and it definitely makes a difference for them. And I also think it's important to make sure that when we do put on the BiPAP, we don't just walk away and forget about these people, because that's where we go wrong, I think, as well. And I mean, I've walked into some ERs where my grandfather fell. One time I took him into ER, and I'm just walking around kind of seeing what's going on, and I see a couple of people on BiPAP who look like they're just not breathing, because
they get put on the machine, and then we walk away and forget about the person. So when we do an intervention like that and we're using it to really help these people or to try and save their lives, we need to remember to reevaluate them and go back. And if that means not leaving the bedside for a few minutes and letting the department back up a little bit, well, maybe we may need to do that. But it's important to make sure that the intervention that we are doing is doing what it's supposed to be doing and not getting worse. And I also think it's important that we do put people on BiPAP a lot, and we have saved a lot of intubations, but not every person that goes on BiPAP is not gonna need to be intubated. I don't know if that makes sense. Basically, there are some people that we put on BiPAP that will still need to be intubated, and just by putting them on BiPAP, we can't just forget about them. We need to constantly reassess them using various different methods.
What I do, especially if they're altered, like hypercapnia can easily be altered. So there's this dogma in emergency medicine and acute care that if a patient is altered, they cannot be on BiPAP or CPAP. Okay, maybe I agree with that if that you're going to walk away with them and not look at them. If you're sitting bedside, what I do is I take a medical student, preferably a third or fourth year, who knows what to look for, and I say babysit them, so sit there by this patient and let me know if they're getting tired or they're not tolerating the BiPAP. And I leave the medical student there when I use sub-dissociative doses of ketamine or Ativan or something to relax the patient so that they can tolerate the BiPAP a little bit better. Ketamine, by the way, I think we mentioned it, it's also a bronchodilator. So you get the effect of bronchodilation, and it's also mildly sedating if you're using subdissociative doses. The only thing to consider is you are also increasing your secretions. So in asthma, you get a lot of junk in your lungs to begin with, so you just have to be careful that if you're using ketamine and BiPAP, you could be pushing some of those secretions down in. So maybe a little glycopyrrolate or something like that. But yeah, I think it's something to use if you're using it appropriately.
I mean, one of the biggest things is that we've now gone more and more towards these non-invasive methods of ventilation. I think it's great. It's improving outcomes. But one of the things that we can really really focus on is the peri-intubation phase, where you have that patient who's unresponsive, and that you probably have them like an end-tidal CO2, and you're actually looking at their PCO2 probably rising. They're kind of going down that route where they need to be intubated. We can utilize CPAP or BiPAP to actually pre-oxygenate them and nitrogen waste them, and actually, that's our main method. So, prior to, our intubations, we talk about, high flow nasal cannula using a non-rebreather, but you can certainly use high flow nasal cannula with a CPAP right on top of there. And then we use that as our method to pre-oxygenate, and then during that peri-intubation period, and then intubate the patient subsequently after an RSI. Like you mentioned, the contraindication for like someone being, altered. I think if you're at the bedside and you're like prepping for the intubation, it's not inappropriate to put someone on CPAP or BiPAP and then prep to intubate them. This is the perfect way to really kind of nitrogen waste them and really kind of oxygenate them well prior to intubating them.
Yeah, and I as we were talking about this article, I was putting pictures of like a normal airway, an asthmatic airway, and then asthmatic airway during an attack. So just keep that in the back of your mind every time you see an asthmatic. Normal airway is nice and open. At baseline, an asthmatic airway is already narrow, and then they get an attack, and you're essentially down to no space at all. So you just got to be careful with these people. It's amazing how in 2017, almost 2018, asthma still kills people. So whatever we can do to prevent that would be useful. Do we have one more article? You want to do the last one quick?
Yeah. All right. So this article is diuretic treatment in heart failure. It kind of reviewed a whole bunch of different topics within the diuretic use and in using it in heart failure, and did a little bit of clarification and a lot of confusion. I think that it's a complicated topic. There's a lot of different properties of diuretics that work in one way, and then in a little bit more time, give it a little bit more time, it starts to work in the opposite way, and it's a lot of kind of stuff to digest and read. I had to read this article a few times. Probably still need to read it another couple of times. But and it kind of starts with talking about how that we use these diuretics a lot of the time. However, there's not really good clinical trials to kind of guide us in how we use it. So there's a lot of questions how to best use the diuretics, especially in people who have acute decompensated heart failure, and then patients who are diuretic resistant. And I think that if you talk to a lot of different doctors and just look at people's practice, you may see the same patient coming in getting various different doses of different diuretics based on what they're on at home, based on what they feel like, based on their kidney function, and
based on the day of the week.
Based on the day of the week, exactly. And there seems to be very little consensus kind of in this area. It talks about loop diuretics in here and how they have complex effects on renal and systemic hemodynamics. It's affected by the route of administration, the dose of administration, what other diseases the patients have, and how frequently they're using diuretics as well. Diuretics that activate the renin-angiotensin-aldosterone system. They dilate blood vessels directly, but they also will increase the level of vasodilatory prostaglandins and pressure within the proximal tubules. So some of these effects, they end up counteracting each other. And, so using high doses of intravenous loop diuretics they can decrease intraarterial pressure, increase stroke volume, decrease renal blood flow. There's a lot of kind of confusion about this and what actually happens. Additionally, there's people who have diuretic resistance that we may be giving them a lot of diuretics, and there in table 1, as you guys can see, there's a whole bunch of different causes diuretic resistance. So, if these people are diuretic resistant and we're using these diuretics in acute decompensated heart failure, are we helping them? Are we doing anything for them? Or are we just giving them a medication that's basically not doing anything? Basically what we want to do with diuretic treatment is not to just get people to pee out some more sodium chloride now, but over time we want to have a negative sodium chloride and water balance, basically. So we want to, and reduce extracellular fluid volume. So we want them to be net down over time. But when we give these diuretics, the half-lives are short. We only give them twice a day, and it's complex the way they work, so maybe it's not doing enough. When we give a dose of a loop diuretic, we'll increase the urine excretion for a couple of hours, but then there's very low sodium excretion because we've peed out a lot of it already. So now we have that the body is trying to hold on to sodium. So we have post-diuretic sodium retention. So when we're trying to induce negative sodium balance, well, then people go and eat. They eat some salty food. Now the body's trying to hold on to all this salt. So now our balance isn't so negative. But if we give this to people and then they're not eating a lot of sodium, then they may get to this state where we're actually able to get more fluid out. So a lot of diet stuff kind of takes, we need to take the diet into account and what the patients are eating and what family members are bringing people. And a lot of this is more, it seems to me from this article, is more of the longer term management, and it doesn't really discuss so much while they do talk a little bit about acute decompensated heart failure, it doesn't really get into so much detail. And really, for me, I didn't feel like it gave me such good clinical guidance as to how to treat this person when I encounter them in the field or when they come in the ER and they're in really bad pulmonary edema or decompensated heart failure. And and it talks about how there's limited evidence and how we talk about practice guidelines that give class 1 recommendations based on level B or C evidence. There's, we look at, and if we look at the dose trial, this was a diuretic optimization strategies and evaluation, and they basically looked at Lasix given twice daily or as a continuous infusion, either low doses or high doses. The low doses was equivalent to the patient's previous oral dose, so the high dose was 2.5 times the previous oral dose. And then all those patients as well received both intravenous boluses every 12 hours and a continuous infusion, one of which contained either the Lasix and others a saline placebo. And this basically didn't show a statistical significance, although there were some more favorable outcomes in the high dose group with regard to some secondary measures, including relief from dyspnea, change in weight, and net fluid loss. But again, this stuff didn't really reach statistical significance. There was a little bit of worsening renal function in the high dose, but did that have an effect on people? Not really sure. So, it's hard. I think it's hard to kind of recommend a good treatment. Using these diuretics based on the literature and the data we have right now. I think it's something that we could consider using. May be good for some patients, may not be good for some patients. Talks about adjuncts to diuretic treatment here. It talks about a medication called tolvaptan, which inhibits tolvaptan, which inhibits the action of antidiuretic hormone and increases excretion of free water. So that sounds like it could be promising. However, in the Everest study, which it didn't really show any superiority over that medication versus placebo in terms of long-term clinical outcomes. If we look at the Rose AHF trial, which is a renal optimization strategies evaluation in acute heart failure. Here we have 360 patients. They were hospitalized for acute decompensated heart failure. They were randomly assigned to furosemide plus dopamine infusion Naseritide or placebo. And the reason for this was that maybe that we think low blood flow contributes to sodium retention in acute decompensated heart failure. So they thought by maybe giving dopamine and increasing the renal blood flow, we may do better for the patients. However, there was the endpoints that they looked at. There was really nothing significant in that. And in fact, even with the low dose dopamine infusion, there were, potentially worse outcomes. So there's a lot of, it goes on and talks about spironolactone and how we use spironolactone to people who have reduced EFs. We use it in low doses to avoid hyperkalemia. So in the Athena HF trial, they looked to see if using a higher dose of spironolactone would increase the primary endpoint of decongestion, but it showed that using the high dose, which was 100 milligrams per day versus placebo, there was really no change in decongestion. So then it talks about a little bit how when diuretics, they don't achieve decongestion despite the maximal doses, which then these patients are considered to be diuretic resistance. And what they said here was that single doses of furosemide, 250 milligrams, are considered to be maximal, although the recommendations vary. So these are pretty high doses, and if we're giving people. So now what happens if we give them these big doses and it doesn't work? So they talked about then using extracorporeal ultrafiltration, where however this also showed that so they did a trial comparing ultrafiltration with the step care pharmacologic approach, which we can see in table 2. It talks about different rates, the different amounts of what we should be giving bolus versus infusion based on what people are on for their previous oral dose. So using ultrafiltration compared to using the dosing in table 2, it showed that there was similar fluid removal, but there was more renal dysfunction, adverse effects with ultrafiltration. It's been proposed using a combination of hypertonic saline with high dose of loop diuretics to mitigate renal dysfunction, although that approach hasn't really been tested in robust trials. So I think this, for me, kind of is a complicated thing to deal with. I don't think that there's any one answer. I think a lot of this stuff kind of now is we try things and we see if it works, and it definitely need to have more trials and potentially better trials to kind of deal with this in the future from here.
Yeah, I think you hit the nail on the head. And initially, when you said, so this study highlighted the fact that the data behind this sucks. Really, the only good paper, and I'm sure Dr. Merlin will vouch for this, is the dose trial, which you talked about. That's really the only thing. Large study has statistical significance, commenting on the effect of large doses of diuretic, right? Dr. Merlin sleeps with this right next to his bed, so he reads it every day when he comes up, and he can quote it line for line and tell you everything about it. So now basically the protocols of multiple EMS systems, ours included, is based on the fact that there's no significant difference in giving large or small doses of diuretics in people who need it. For me, I like to have a little bit of a history in the patient of, okay, I just had Thanksgiving. I had a lot of salt lately, so I know my volume status is up. Or I sat with a gallon water jug next to me as I sleep, and I wake up periodically in the middle of the night and I drink a lot of water. So I like to have a little history. Or I forgot to take my Lasix for the last 20 days. Something like that to kind of helps me justify giving it. But the reality is we didn't have that history in the whole patient population for the dose trial, so they didn't require that in their inclusion. So,
most of the time these patients, if you with a dose trial, they're not getting a bolus up front. They're just getting the continuous infusion as well. Whether you do that or not, for our purposes, the pre-hospital arena, does this make any change in our practice? Is the question.
Yeah, I don't think reading this is going to change my practice. I think if I still see someone with acute decompensated heart failure, I am going to use BiPAP, I'm going to use nitro, and then I will think about giving them diuretics somewhere down the line. I don't think diuretics are going to start working right away. I'm not sure that I'm not sure if we're dealing with intravascular volume, extravascular volume. Are we really diuresing the right part that we need to be diuresing? I think looking at the patients and reevaluating them and making sure they're getting better, that they report they're getting better, their numbers are getting better, they're feeling better, they're breathing better. That's how I'm gonna treat at this point.
And a lot of it depends on all of that. So it depends on where they are on the Frank-Starling curve, whatever. So I as you were talking about the article, I pictured the Frank-Starling curve up here so people can see, But it depends how stretchy their heart is and how much volume's in there and why it's that big. So and now I just have a summary slide of the dose trial up there with the picture of the tubule so you can see where it's actually these loop diuretics are working. But if anybody's interested, I'll get rid of them. Okay.
So for us pre-hospital, the biggest difference is just as with CPAP and nitrates, whether we give 20 milligrams of Lasix or we're giving the 1 milligram per kilogram 5-6 years ago, the difference was always just the frontline treatments of CPAP and nitrates. So it certainly doesn't change what we're doing in general. I think the biggest change happened when we moved to push dose nitro
for failure patients. That's the biggest thing we've done since because 5-6 years ago when we talked about changing Lasix dosages was nice, but it doesn't change what we're doing at all.
We get laughed at a lot by cardiologists in the ED and pre-hospitally for how much we use nitroglycerin. But the reality is that's the only thing. It's quick on, it's quick off. It reduces preload first. It also reduces afterload in large doses, and that's exactly what these people need. They need positive pressure and they need preload reduction. Those are the first priorities. I know Dr. Tagore taught me the kitchen sink analogy when I was a resident. That's what I live by. You have your inflow, you have the size of the sink, and then you have your outflow. You have to affect all of those, and nitroglycerin does that, right? So it's a great drug. Sorry, cardiologists.
Well, the best thing with push dose nitro or with the drip is you can just stop it.
Right.
Like you shut it off and then it's done.
You can see aggressive management. So, how many times are we giving paramedic dosing of something on nitro?
Never.
What? But that's what we're doing essentially. We're giving 800 micrograms, 1200 micrograms sublingually, and what we're doing is we're seeing it kind of go over 4 minutes. And if you titrate that out, we're giving 400 micrograms a minute. And that's okay.
Right.
There's not a problem with that.
Well, that was the argument when it first started. Was I don't want to give that much nitro. It's like, well, but you're giving that anyway.
Exactly.
You're just giving it in a different form.
It's interesting that people will give 400 micrograms of sublingual nitro, and so effectively they're getting 100 micrograms a minute.
Right.
But they don't want to start a tidal drip greater than 50, or 100. It's like we're going backwards here, and so at least we're moving in the right direction where push dose is kind of taking over a little bit better. People are recognizing that higher doses of starting a tidal drip at 200 even is appropriate. So that's the best way to go. You have a patient in CHF exacerbation, putting them on CPAP and then giving them push dose tidal 400 micrograms every 2 to 3 minutes even is perfect. And then later on we can talk about augmenting our afterload as well, and most of the time it's usually with an alloprol IV or maybe a hydralazine, and that's going to help them from that kitchen sink perspective, opening up that drain and kind of helping them in their afterload. So afterload reducers are key, but really you're just going to continue your nitro, and the threshold for your using your nitro, many people are very kind of worrisome. They stop at 100, 120 or so systolic. I drive my systolic all the way down to 100 even. And I'll continue it as long as I know this patient's symptomatic and working hard and compensating essentially. Yeah. Any other comments?
I would just love for some of the cardiologists who criticize our use of nitro. I'm going to start wearing a GoPro when the patient comes in, and you see that pressure, and you see their diaphoretic, and you see how hard they're working. And how quickly nitroglycerin works plus positive pressure. You turn them around, and it's kind of a game we play as emergency physicians and as acute care clinicians. Yeah, you don't want to intubate this patient, and a lot of the time, 10 years ago, everybody was intubated. Right?
Absolutely.
Now, nobody's intubated, and it's if you have to intubate a CHF, everybody's like, ooh,
I mean, if you talk to some of the younger medics, I mean, how many times have they seen pink frothy sputum from an ET tube?
Well, and the other thing is, like,
and they're not seeing it anymore because
we also
we're
have
actually appropriately resuscitating patients.
Yeah, well, and we also have to convince some of the ED physicians how sick the patient was initially when we first got to them now.
Absolutely.
As opposed to, from 10 years ago, but yeah.
And now earlier intervention, a lot of these patients are coming in, they're being obsed for a few hours, diuresed, and then they're going home. They're not getting admitted to the ICU. So I think it's made a profound difference.
Where we used to intubate those patients all the time.
Yeah.
Yep.
When I first started, they would get intubated.
Throw the
right
tube
away.
down.
Yeah. Snow them, and tube them.
Yeah, and the side of that is, sure they have left ventricular failure, but if their right ventricle's affected as well, anybody with right ventricular failure, if you come towards them with a laryngoscope blade, you're essentially killing them. You know, their mortality is so high. All you have to do is touch them. Scott Weingart calls it the you have a license to kill with your scope. So you just have to be really careful.
All right, I think that concludes Journal Club for today.
Thank you very much.
We went a little bit over. Sorry. Merlin will join us next time. I believe next week we're off.
Next week we're off for the holidays.
Yeah, we'll be here, but I mean we won't be having Journal Club.
I mean, we could broadcast if you want, but it's not going to be any worthwhile discussion.
We'll see. We'll send out an email again if you want to join the email list or see anything. Go to our website at emsfellowship.com. There's also places on there to join other events and see what else we're doing. Don't forget we're announcing now the EMS Week conference that we're organizing. I believe it's Tuesday. There's a link on the Facebook page.
May 22nd?
Yeah. Registers. And we'll see you all there.
I'll try to put that info I'll try to put that info into the thing when we do it. So once I edit it. So.
All right. Thank you.
Thank you.
All right. We are